Hold on.
Welcome, everyone. My name is Jess Pelletier. I recognize most of the names on here. I'm the medical director for Techies Without Borders, and I'm here with Nick Maxwell, our medical education coordinator. And today, Nick is going to be leading a session on pacemaker issues. So, as a reminder, if you've been here before, and for those who haven't been here before, these sessions are meant to be engaging. We're hoping to have people participate either in the chat or out loud. So if you have questions or thoughts during the session, please do chime in. I'll leave the poll open for another couple of minutes. That gives us an idea about folks' baseline level of understanding of the concepts we're talking about. And then at the end of the session, we'll go through the answers to these questions. So without further ado, I'll let Nick get started. And again, please do participate and answer questions when he asks them. Thank you, everyone.
All right. Hello, everyone. Without further ado, we'll get started. So today we've already started our introduction. We'll start out with a brief case, and then we'll get right into talking about pacemakers, its types, the indication for pacemaker placement, how pacemakers work, pacemaker problems and troubleshooting, as well as some EKG practice, and we'll have a wrap up at the end. All right. So without further ado, we'll get started with the case. So you have a 75-year-old male that comes into the emergency department with a past medical history notable for third-degree heart block, who now has an implanted pacemaker, who presents with lightheadedness. His vital signs are a heart rate of 30, a respiratory rate of 18, a temperature of 37, an O2 saturation of 92% on room air, and a blood pressure of 60/30. On exam, you see one of these. And I'm really curious to know what you think your immediate next steps would be and what might be going on with this patient. Sorry, got my chat coming up here. Oh, we have people coming from the Gambia. Wonderful. Welcome, everyone. Okay. All right, we can get some guesses going. Who thinks they know what's going on, or one thing that might be going on with this patient?
The doctor who started what the one who died for 90 is the
Stephen, your audio is a little muffled. I'm not sure if you're answering the question. Feel free to type in the chat because we can't quite hear you.
All right, so I mean, I think some of the basic first steps would be to get the patient on the monitor, right? You want to see what the rhythm might be, get an EKG. Definitely want to start on the exam to see if you think that they might benefit from fluids for their blood pressure, if they're mentating well. They do report lightheadedness, but do you need to do something emergently, like pacing or start doing vasopressors for an acutely ill patient? But with this patient, in this setting, we're going to be talking about pacers. And so very clear, this might be one of the problems that's going on, especially in this patient that appears to have a pacemaker in the left side of their chest. So for traditional types of pacemakers, there's three main categories we'll go into. The first is a single chamber. So you can see these here. Hold on. I'm working with a small screen here, so I have to do a lot of shifting around. So this is where you'll usually have it implanted typically in the left side of the chest. And there's a lead that goes in through the subclavian vein and goes into one of the chambers of the heart. Oftentimes the right ventricle, sometimes the right atrium. And then it can pace the heart from that section. Another type is a dual chamber pacemaker. And these can go or often go in the right atrium and the right ventricle, right? So that way you can have a pace beat going from the atrium, so you can get that atrial kick, and then also into the ventricle, so you can get that big ventricular squeeze. The third main type that we'll talk about is biventricular, and that's where you're going to have both of the ventricles paced. And oftentimes, in order to reach the left ventricle, you actually go through the coronary sinus to pace that. So you would actually have three leads, potentially in a biventricular pacemaker. And so one would be the right atrium, the right ventricle, and then one would be pacing the through the coronary sinus to the left ventricle. And there are variations of this, and this is not a comprehensive list of ways that they can incorporate this, but these are some of the more common ones. And oftentimes on X-ray, this is what it looks like. I don't know if you can see my mouse or not, but a lot of times you see a very prominent pacemaker in the leads in the chest there. And then you can see them coming up through the vasculature and then down into the heart. And if you're ever wondering for things about imaging, Radiopaedia is a phenomenal website that has tons of images that you can look at to learn from, and descriptions and explanations about them, including even full CT scans that you can scroll through. Oh, here. That was just supposed to stay from the last slide. But something that can throw you off are leadless pacemakers. And I actually learned about these not too long ago, primarily because we had a patient come in that reportedly had a pacemaker, and we got a chest x-ray and it looked like this. And we're like, there's no pacemaker up there. What are they talking about? But we actually learned that there's these leadless pacemakers. And if you look kind of in the patient's left side of the chest and the heart there, there's what almost looks like a little pill. And that is actually an implanted pacemaker. Oh, I think I'm hearing a monitor from someone. But so these can be sneaky, because if you just look up in the left chest to try and find a pacemaker, you'll miss it and make an inappropriate assumption when really they might have one there. And there's a couple different brands, I believe, that make these. But then on the left here, we can see that the pacer goes down in there and it can sense beats and pace as well. So what might be some common indications for a cardiologist to place a pacemaker in a patient? Lost my chat. Oh, there we go. Yeah, complete heart block. Good, good. What's another name for a complete heart block? Or CHB. Thank you, Michael. We're kind of lucky because we have learners of various different levels here. So, for example, Nazra's this is their first lecture on pacemakers, and so using advanced terminology and being able to explain it down will be really helpful to kind of target all levels of attendees here. Yeah, so a third degree atrioventricular dissociation. Yeah. So basically, there's no conduction from the atria down to the ventricles. Good. Or a high grade second degree block. Yeah, so sometimes these are called a second degree type 2 atrioventricular block, or sometimes people call these a Mobitz 2. I like to avoid using the eponyms, just because I think it can be an extra thing to remember. People might not use them, and sometimes they're associated with not always the best people, so there's a lot of changes in those. But yeah, a lot of times when people talk about a high degree or high grade AV block, they're talking about a second degree type 2 or a third degree AV block. Good. And the overarching concept is basically their heart's not working, the conduction system in their heart isn't working well enough and reliably enough to trust it on its own. So you hit the right things, right? So a lot of times they're going to have a symptomatic bradycardia or a high risk rhythm. And so examples might be a second degree type 2 heart block, a third degree heart block, sinus node disease, so sick sinus syndrome, or sinus arrest with prolonged pauses, right? So you might not have a huge AV block, but if your sinus node's not working, that's going to be a huge problem. So we want to put something in that's going to take over that that automaticity, or that starting of the heartbeat when your heart's failing to do so. And the indications often drive what type of uh, pacer you might want, right? So depending on the problems you have or why your heart's a problem or other comorbidities you have, you might want to have different ones. So for example, if you had a single lead pacer that went to the right atrium, but you have a third-degree heart block, that's not going to solve your problem because the problem is conduction down to the ventricles, right? But if you really need that atrial kick, just having a ventricular lead might not be enough for you. So you might want both an atrial and a ventricular. And this is what a common pacemaker might look like. So you see the little device here, and then the leads that would go through the blood vessels to actually reach the heart. And then at the tip is where you get a lot of the impact of the sensing and the pacing. So there's kind of three main aspects that we oftentimes think about when we think about pacemakers. There's the pacing, the sensing, and what they do when they sense. So sometimes you'll see really big tables like this, and they'll talk about 5 categories. For our purposes, we're going to focus on the first 3, which are the main ones that people commonly discuss. So if you see like a pacer and somebody says, "Oh, they're in DDD or VOO," this is usually what they're referring to. So in position 1, it's talking about the pacing. So if you had O, that would suggest that it doesn't pace either chamber. Whereas if it had an A, that suggests it can pace the atrium. As a V, it can pace the ventricle. Or D, that's for dual, it can pace the atria and the ventricles. Welcome. Looks like we're getting visitors from all over. We're getting Uganda, the Gambia, Tanzania, Ghana. Thank you so much for coming, everybody. Feel free to chime in anywhere along with questions or comments. This is meant to be interactive, so happy to have people chime in. The second letter is going to be what it does when it's going to try and sense things. So if it has an A in the second space, it's going to sense for atrial beats, or if it has a V, it's going to sense the ventricle, or D, it's going to sense both atria and ventricular beats. And then position 3 is what it does when it senses those. And so it can either trigger a beat or inhibit for the atria and the ventricles. So we've kind of talked about the different kinds so far, so that there's the single chamber, the dual chamber, or biventricular. And with those, anytime, I like to say, anytime the healthcare is involved, it could also be associated with the problem that presents. And so there's a couple main malfunctions that we'll talk about. And those are a failure to sense, a failure to pace, and a failure to capture. If we get time, we can talk about runaway pacemakers at the end. So, joining from Makerere, and welcome. So, for failure to sense, this EKG is an example of what failure to sense might look like. So, who can describe what we see on this EKG? All right, so do we see P waves on the EKG or QRS complexes?
Yeah, Michael, you answered the question correctly. I'm curious if you can describe what that means. What do we see going on here?
So we can see, so we do see the small P waves, right? So I don't know if you can see my cursor, but like if you see the wide QRS in the middle, you see a PRS or a P wave before it, and a tall little spike on top of it. Oh wait, the pacing spiker on top of the P waves. Perfect, Michael. Thank you so much. So yeah, so we're seeing the P waves and the QRS complexes, but it's also trying to pace, right? That's what this little spike is the pacemaker like sending out some electricity to try and start a beat. But what it should be doing is it should be detecting that there's this atrial beat here and going, oh, wait a minute, it doesn't need my help. It's already got it. And so this is a failure to sense that the heart is beating appropriately. And so what you might see is the pacer spikes despite appropriate intrinsic electrical activity. And then what you can do about that is you can consider applying one of those blue magnets if you have them. And the idea behind that is it tries to set the pacemaker into kind of the most simple mode. And that's just where it'll pace empirically at a set rate, a set default rate. But you also want to try to correct any underlying causes of why this could be happening, like electrolyte abnormalities. So if somebody's got a very abnormal potassium, it might make it harder for the heart to respond to things like pacing. And so sometimes it's not that the pacer's the problem, it's that the pacer is struggling to solve the problem that your body's facing. I'm curious, who has access to magnets for pacemakers? And it's a very specific magnet, right? It's not just any like red horseshoe shaped magnet, right? It's the blue magnets. I can pull up a picture in a little bit. Does anybody have magnets or willing to chime in and say they don't have magnets at their hospital? A lot of times you might see them on your crash carts or by your cardiac monitors or defibrillators.
It sounds like Michael doesn't have one at his shop. Dr. Nick, would you mind explaining what the purpose is of the magnet and what it's doing here?
Yeah, so the magnet, what you can do is it basically you put it over the pacer itself, and that stops it from trying to do its elaborate sensing and responding pacing, and it goes directly into an asynchronous pacing mode. And so it's kind of like a default mode. And so that way, if there's a problem with sensing or something of that nature, it'll just go into a set rate pacing to try and provide some stability while things are going on or malfunctioning or trying to troubleshoot an underlying cause. But so, and that's part of why a lot of times you'll see these next to your electrical equipment of your defibrillator or your AEDs or crash carts. All right. So another one, we're going to talk about failure to pace. And so the idea here is we already know, like it even says on the strip, what is happening, but I want you to describe what you see. Because the goal is not to get the right answer. The goal is to understand the whys behind it. So in this rhythm strip here, what do you see going on? Good. Yeah, there are no P waves here, right? This is a patient that's in atrial fibrillation. And so early on, we see a big pacer spike here, a pacer spike here in the setting of no P waves, right? And then after the pacer spike, we see a big QRS complex. And then what stands out? Yeah, a long pause. Thanks, Ruth. Yeah. So, lack of intrinsic connection to pacing. Yeah, exactly, right? So we would expect um pacer spike beat, lack of a beat. So then we would expect a pacer spike followed by another beat, pacer spike followed by another beat. And we do see one down here, right? But we would expect something in the middle there. And so this is a failure to pace. And so you nailed it right on the head. So you see the bradycardia that usually the pacer's in for, but not the indicated pacer spikes. The heart responds well when it gets paced, but the pacer is not delivering the electricity. And so what you can do when this happens is you can attempt magnet placement, but I don't like that. But otherwise, if you have a failure to get the pacing going, is you might have to do something to work around it, right? You might need to consider transcutaneous pacing, transvenous pacing, or even a chronotrope like epinephrine or isoproterenol. Do any of you have access to transcutaneous pacing or transvenous pacing at your hospital? Oh, very cool. Michael, have you ever gotten to transcutaneously pace somebody or seen pacing done? Ruth has transcutaneous pacing. Cool. Welcome, Jane. Very cool. So it looks like some people have access to pacing, some people don't. Does anybody, I see transcutaneous pacing. Does anybody have access to transvenous pacing? Okay, so yes, we have access to it in Ghana, but it's really expensive. That's fair. It's a very aggressive and invasive procedure. For those who saw transcutaneous pacing, how did it go? Did the patient seem to get better? Did they tolerate it? Um, did it improve the heart rate but not the patient condition? What did you notice about how it went? Awesome. They got better. Nice. A bit of sedation, yep. Yeah, one of the things that I thought was really interesting, so when I was a paramedic, we could do transcutaneous pacing on the ambulance, which I only ran into once. But I expected it to be this crazy aggressive thing, just like a defibrillation, but repeatedly. And sometimes it's actually fairly well tolerated. Sometimes they do need a little bit of sedation, or maybe a lot of sedation, depending. Um, but in the morning, where I work now as an ER doctor, in the mornings at shift change, we have a 5 minute like educational talk on various topics. And one day, one of our consulting ER docs, Dr. McCarran, did one on transcutaneous pacing, and he actually paced himself to demonstrate how safe the procedure was, and how tolerable it could be. I'm not recommending anybody does that, But that I saw a video of it and that was just wild to me. But it can be extremely effective for people who need it. But it can be very terrifying, especially like for the provider team as well, because we're shocking somebody to make their heart beat how we want it to. But Jess knows Dr. McCarran. So yeah, there's a video going around of him pacing himself for daily dose. All right. And then, all right. So then this one, failure to capture. What do we see going on here? And again, you already kind of know the answer of what is happening. But what do you see? So to start, do we see pacer spikes?
Tecnicamente come c'è già varieri.
Michael, you got it.
Michael's on top of it. I love it. Thanks for participating. Yeah, so we're seeing pacer spikes. You see two effectively for each QRS. So one is a small spike, and that's supposed to be for the atria, right? And then the bigger one is supposed to be for the ventricles. And we see after each big spike, we are seeing a QRS complex, right? A depolarization of the ventricle. However, we're not seeing anything after these smaller spikes, which are presumably for the atria. And so what we actually have here is we have failure to get capture in the atria, but success at getting capture in the ventricles. And so this is one of those reasons where you got to be very astute, because if you just put the patient, if you had a set of vital signs on this patient, you might not notice an abnormality, right? If they're having good ventricular responses and now granted, the intervals here are not reflective of a normal EKG, because otherwise this would be a ridiculously slow rate. But if you had somebody who had failure to have atrial capture but success at having ventricular capture, the heart rate on the pulse ox or the palpable heart rate might be within normal limits. You might not detect that, but if you get an EKG, you could see that the pacer is starting to struggle. Oh, thank you for speaking up, Nazra. So failure to get capture means that the pacer fired trying to cause a beat, but the heart didn't respond to it, right? So it didn't capture the stimulus and start the beat is kind of one way of thinking about it. So in this case, it's not that the pacer is failing to provide the electricity, it's that the heart is failing to respond to it. It's kind of like it threw the ball, but nobody caught it kind of thing. All right, so you might see the bradycardia and the pacer spikes, but not the correlating depolarizations. And so here, pacer spike, no atrial depolarization here. And so for this, depending on how well they're doing, you might need to consider transcutaneous pacing or transvenous pacing or chronotropes. If you had like a failure to have ventricular capture, right, then you might need to get aggressive. But sometimes patients tolerate this fairly well, at least temporarily. I had a lady once who had a heart rate of 29 because she had a complete heart block, and her blood pressure was over 100 systolic. Her respiratory rate was within normal limits. Her oxygenation was in normal limits. She could talk to you. She said she felt great, except she was just a little bit tired. But she could have a full conversation even though her heart was only beating 29 times a minute. She did not yet have a pacer. She got a pacer. But so you'd be surprised sometimes. It's easy to assume that things might be going better than they are, until you actually really dig deeper. So then there's also some mechanical malfunction. So as you can imagine, when somebody has a surgery to place a pacemaker, right, you can get infections, You can get bleeding and hematomas. One of the interesting things you can see sometimes is lead dislodgement. And has anyone here ever heard of Twiddler syndrome? Oh, nailed it, Michael, right on top of it. So now so Twiddler syndrome is a occurrence where when somebody gets the pacemaker placed, they kind of fidget with it a little bit. And because they feel this weird thing in their chest and they fidget with it. You might especially run into this in elderly patients with like dementia because they might be a little confused, they might have forgotten about it, or they might be delirious, or their skin and soft tissue is a little bit looser. And they kind of just kind of roll it around and fidget with it. And you can even see that it can cause these leads to coil up. You see, so you see the pacer, and then right above it, there's almost like a knot of the pacer wires. And so they kind of twiddle with it, and that causes the leads to get displaced. And so you can actually see kind of under the curl of this first rib here, you can actually see the edge of the atrial pacing wire. The ventricular one goes to the heart, but it's not in the right ventricle, right? And the right atrial one is way over here in the left subclavian. And so you would likely not be getting good pacing as a result of this. But you'd see a pacemaker there, you'd see it on your x-ray. Depending on where this wire is, you might actually see some conduction and what kind of settings it's on. But so the leads are way out of place and need to get adjusted. Another one's lead fracture, right? So this is an actual damaging of the lead itself. And so if we look right down above the pacer, right around the box, if you will, you see there's a little loop, and you can see there's a little break in that loop. And that's actually a fracture of the pacing wire. And so you might not have any conduction of pacing through that lead. And so therefore maybe you have good pacing through the other lead, but not that one. And so you might not see what you anticipate with your pacer. All right. Now I got a couple here we can practice where I didn't tell the answer at the top of the slide. But this one's a bit of a beginner one. What do you see on this one? All right, so do we see uh, P waves and QRS complexes anywhere on the EKG? All right, so we have some P waves and QRS complexes, and we also see some pacer spikes. Now, do we see P waves and QRS complexes after all of our pacer spikes? Sort of right. So yeah, so Michael, so we don't see uh depolarizations after our pacer spikes, but is it a failure to pace, or is it a different kind of failure, right? Because the pacer spikes, the pacer's firing the charges. Yeah, good. So it's no capture, it's failure to capture, right? The pacer's firing, it's just not actually getting the beats that are supposed to respond to it. And so if somebody had a really high potassium, for example, those tend to not respond as well to pacing or just like electricity in general. And so sometimes the underlying problems can make it harder for the pacer to work, even though the device itself is functioning appropriately. So this is a failure to capture. And actually, the underlying rhythm, like it actually has a P wave QRS. P wave QRS, it's just slow. Um, all right, so here's another one. What do we think's going on here? All right, so we see P wave, QRS, T wave, P wave, QRS, T wave. Okay, I see. Sorry, thank you, Michael. Pacing spikes on top of QRS complexes. Good. So out of the three kind of categories we talked about, would that be a failure to sense, a failure to pace, or a failure to capture? Yeah, good. Right. So it's firing a pacer spike. Oh, awesome. Great job, Favor, too. Both Michael and Favor got that right. So it's firing a pacer like depolarization right over a QRS complex effectively. And so it's failing to detect that the heart was creating beats appropriately and firing anyway. So this would be a failure to sense. And admittedly, this one's a little bit tricky because there's no pacer spikes in places where it could have responded to it because it's in the refractory period. But we also don't know if these pacer spikes would be associated with capture if they weren't over a QRS. But yeah, so at the very least, this is a failure to sense. Good job. Um, Now I would love to know how many of your institutions implant pacemakers and how often do you actually see pacemakers at your institution? Earlier, when I was trying to keep up with the chat, it looks like we have people from the Gambia, Tanzania, Uganda, Ghana, Nigeria, at the very least. I might have missed some as well. But we have a pretty diverse group here today. Okay. So one person hasn't come across somebody with the pacemaker. Okay. But hopefully now you feel a little bit more ready in case you do see one. Okay, Michael's seen people with pacemakers.
I will say I've seen a lot of electrical issues like pacing, sensing, and capturing problems. And in my experience, a lot of these have been due to either issues with electrolytes, so especially potassium issues, either hypo or hyperkalemia. I've seen some due to cardiac ischemia. So if you have tissue that's ischemic, it's not going to conduct electricity well. We don't see mechanical failures as often. Those are pretty rare, but they do happen. And so I think it's important if you have access to a chest x-ray to rule out a mechanical issue as the cause for the pacemaker not working. I will never forget, actually, as a medical student, I had a woman come in who had just had a pacemaker placed and said she was having sharp stabbing chest pain and she felt like she was being poked in the chest. I got a chest x-ray and it turned out that her pacemaker lead had perforated her ventricle and was actually poking the inside of her chest wall. So that was a really good reason for her to have poking chest pain. And it answered our question very quickly. Ironically, the radiologist missed it on the chest x-ray. We ended up getting a chest CT to confirm, and he also did not see that it had perforated. So we ended up transferring the patient to a larger tertiary care center without a radiologist ever recognizing the problem. So be sure to read your own imaging and also rule out mechanical problems before you assume it's an electrical issue.
I hope she used the phrase sharp stabbing pain. That is like the perfect opportunity.
Yeah, Emmanuel has his hand up. Go ahead, Emmanuel.
Okay, thank you so much, Jessica. Nick Maxwell, quite a nice session so far. I just have a few comments to just put on in here. I've listened so far. I would just want to highlight some areas that I feel you should rather elaborate much more on. First and foremost, indications of pacemaker insertion has been told the audience. The contraindications to pacemaker insertion is also very, very important. When not to, very, very important. As specialists, you must know when not to put a pacemaker. Then the striking features are picked at the level of the rhythm strips that you are reading is very, very important. It's a spot diagnosis where the key elements, the P waves, the key RS complex, and other parts of the waves must be quickly interpreted in the light of the patient presentation, not just an outright EKG interpretation without marrying it with patient presentation. Then management of pacemaker insertion complications is very, very important, either mechanical or otherwise, as it may apply. Then the issues coming from pacemaker itself is very, very important. Pacemaker related issues, the cardiac issues, is it mechanical, is it electrical, is it electromechanical, as it may apply. Then the extracardiac events are also, for example, the comorbidities of the patient are also very important. Then the pacemaker insertion skills is a skill set that people must be conversant with. I have seen that quite a number of centers do not have access to this emergency life-saving procedures. We should reach out to other places where you can glean and get to learn some of these skills, either transvenous or transcutaneous. For example, in Nigeria, we have quite a number of cardiac centers where these resources or access to these life-saving skills are there. Then the underlying cause, you must not just be cutting the leaves without taking out the root. What is the underlying cause? Is it cardiac? Is it extracardiac? Is it metabolic? Is it electrical? Is it mechanical? These are some of the things to look at. Then in situations where there are constraints, like we've seen a number of responses from people here, limited resource centers, where there are no pacemaker, what are the things that people can do as life-saving skills at those times? When to give patients in inotropes or chronotropes, and when not to, because there are some specific inotropes that will be rather damaging for the patient. Then pacemaker and imaging modalities are things that we must marry side by side. Yes, the X-ray is very, very important. You've talked about dislodgement, fracture, etc., etc. But in the case of CTs, ENSME, and other neuroimaging modalities, what are the issues? These are some of the things that are going to help practice and is going to help people preparing for exams, maybe ABEM or something. Thank you so much. Over, Nick. Thank you, Jessica.
Emmanuel, that was fantastic. Thank you. And just to kind of recap some of the things that he touched on here, this is just a basic introduction, but if you are not familiar with pacemakers and you have someone come in with one of these problems, you really need to talk to a specialist if you have one available to you, or to an emergency medicine physician if you have one available to you. Don't be afraid to consult your resources, because this may not be a familiar issue in your setting, especially if pacemakers are not common where you work. I also appreciated Emmanuel said you can't just look at the EKG. You have to look at the clinical picture of the patient in front of you. So if a patient is coming in and their EKG has one of these issues on it, it looks like failure to pace, sense, or capture, but the patient looks fine. They're not hypotensive, they're not bradycardic, they feel okay, then you can probably take a little bit more time to get help, as opposed to the patient who is acutely crashing, dying, where you really need to think about ABCs, airway, breathing, circulation right away. And you may need to consider taking control if you have access to things like pacing. Emmanuel also touched on What are contraindications to pacing? So if someone's pacemaker is failing and you need to take control, you need to consider, do you have availability of a transcutaneous pacemaker or a transvenous pacemaker at your shop? We definitely should not be putting in transvenous pacemakers if we're not trained how to do that. That would be certainly concerning and dangerous. That's an invasive procedure. So that should be deferred to an emergency medicine physician or to a specialist like cardiology, vascular surgery, that kind of thing. And then for transcutaneous pacing, there's not as many contraindications, but we do need to think about whether it's going to work or not. And so if someone has a lot of chest wall hair, definitely need to shave that off before you try to transcutaneously pace them. You can't do it if someone's chest is wet, because the wetness is going to cause danger to people around them. You don't want to have the water falling on the bed and then staff member touching the bed and getting shocked and things like that. So, and please make sure if you're going to transcutaneously pace someone that you treat their pain. I think someone else in the chat mentioned that they would do sedation. I believe that was Michael. If you are going to transcutaneously pace someone, it's incredibly painful. So we're not going to get into the ins and outs of how to transcutaneously pace today, but please do remember that these are not things we should be doing if we don't know how. And we won't get deeply into inotropes today, but if you have things at your disposal like atropine or isoproterenol, dobutamine, dopamine, we probably should not be starting these without consultation from an emergency medicine physician or a cardiologist. But those are alternative options if someone's pacemaker is failing and you don't have a transcutaneous or transvenous pacemaker available to you. Nick, do you have anything to add to that?
No, not really. I think you really hit it on the head. Like this is an introduction talk. This is by no means comprehensive. Don't go out of your depth, right? Like just because you heard about transvenous pacing doesn't mean you can do it necessarily. You need to get trained on that skill and make sure it's the appropriate patient, as Dr. Manuel said. Make sure you're treating the whole patient, not just the monitor, right? So we focused a lot on, the pacemaker device here and the EKG here, but that's not the whole picture, right? There's a patient attached to that. And if you just treat the monitor, you're not going to successfully treat the patient necessarily. But know what resources are at your disposal and who you have to collaborate with in order to give the best care to the patient.
Nick, do you mind advancing the slide? I think we'll go through some summary or take-home points. Ooh. How about I share my screen, because I think yours isn't refreshed. Let's do that. All right, hang tight for 1 second, guys. Okay, can you see my screen? Okay, just to summarize here, so pacemakers help manage heart blocks and symptomatic bradycardia. We'll go through the answers to the multiple choice questions in just a couple minutes, but those are the key indications. You can have, or if you have electrical capture, that means you have a pacer spike followed by either a P wave or a QRS complex, depending on whether it's atrial or ventricularly paced. You have mechanical capture if you have a good heart rate and blood pressure in response to that. So if someone looks like on the EKG that you have a pacer spike and then a P wave, or a pacer spike and then a QRS complex, but they're hypotensive and bradycardic, you may not have mechanical capture. You might only have electrical capture. So you need to, again, look at the patient in front of you to determine if the pacemaker is working. You can have mechanical or electrical issues like we discussed. Mechanical are not as common, but you can have things like lead fracture or displacement. You can have leads that actually perforate through a ventricle or an atrium. That's very rare, but it happens. And you can have things like Twiddler syndrome, where someone's fiddling or playing with their pacemaker and it causes the leads to get twisted up and stop working effectively. Electrical issues can include failure to pace, sense, and capture. So again, failure to pace means exactly what it says. So you might have a spike, but you don't have a corresponding capture, or sorry, you don't have a corresponding P wave or QRS complex. Failure to sense means that the heart is doing things, but the pacemaker is not aware of it. And then failure to capture means that you're not actually, the QRS complexes and P waves are not happening in response to the pacemaker. You need to stabilize ABCs and seek help early. And so again, consult an emergency physician or cardiologist if you do not know what to do with one of these patients. And then these are Nick's references. I'm going to post the link to the evaluation again in the chat, but let me share the results of the poll so we can go through them. Are you guys able to see the poll results? Is that popping up on anyone's screen?
Yes, Jesse.
Okay, perfect. So to go through question 1, which condition is not typically listed as an indication for pacemaker implantation? So the answer here would be sustained ventricular tachycardia, not amenable to other treatments. If someone's having recurrent ventricular tachycardia, they really need to have a defibrillator implanted, so an AICD rather than just a pacemaker. I suppose you could do overdrive pacing, but typically sustained ventricular tachycardia is not an indication for a pacemaker alone. You'd need to have a combined device that can defibrillate and pace. When identifying pacemaker activity on an EKG, what specific finding indicates ventricular pacing? So that means there's a spike before the QRS complex. So it's the third answer. So if the first answer choice here, a spike observed before the P wave, that would be a atrial pacing situation. And then the second answer, 2 spikes, one before the P wave and one before the QRS complex, would be both atrial and ventricular pacing. For the third question, you're going to have pacemaker complications broadly lumped into mechanical or electrical. And then for the last question, which of the following sets represents 3 common electrical pacemaker malfunctions? We talked about these a lot, but pacing, sensing, and capturing are the 3 issues that you can have. Nick and I will send out the answers to these questions along with the meeting summary. And I'm going to turn things back over to Nick.
Oh, that's all I have. I just want to say thank everybody for coming, and thank you everybody who participated, especially Michael. I really appreciate you chiming in the chat, and Nazra asking questions, Dr. Emmanuel for adding at the end. Very helpful, and I love the participation. Thank you, everyone.
Thank you, Nick.
Oh, lovely, Nick. Lovely, Jessica. It's warm, everyone from across the world.
Thank you so much, everyone. I'm going to paste the link to the evaluation again. If you could please submit feedback at the link, we would really appreciate it. That helps us to make these sessions better. And thank you to everyone who participated and was so engaged today.
Thank you, Jessica, for the invitation.
Absolutely.
Lovely.
Thank you, Emmanuel. We appreciate your expertise and your feedback during the session. It was so helpful. And Rebecca asked this, whether we'll be posting the video. Yes, all of our Journal Club videos get posted on our YouTube site for Techies Without Borders. Dr. Nick and I will be writing a session summary, so it will have all the key points inside the document, and there will be a link to the recording in that document. Thanks, guys.
Thank you, Jess.
Thanks, Michael.
Okay, however, is it? I don't know.
Well done, Nick.